released in 2020. So what is, according to NHS, what should be the ideal method of screening nowadays? They give priority to
They give priority to.
it or cytology, which is better according to the NHS.
Okay, more sin. Okay.
Huh? Which is better, HPV, primary HPV testing or cytology? What does NHS say?
HPV, primary HPV screening
Primary HPV screening is much better.
than
Why? Because
cytology.
it is more sensitive and high negative predictive value.
Okay.
Okay. So if it is negative, you can even do it at 5 yearly interval. That's what they
Okay.
say.
Okay.
So how do you go about in the screening, NHS cervical screening program? So
Okay.
you start it at 24 and a half years of age. The
Okay.
person gets the first invitation.
Okay.
Then from 24 and a half to 49 every 3 yearly,
Okay.
followed by from 50 to 64 years every 5 yearly.
Okay.
Okay, so this you have to know. The first invitation at 24 and a half years, every
Okay.
3 yearly up to 49, and from 50 to 64 every 5 yearly.
Okay.
Okay. So before 24 and a half, no invitation. First
Okay.
invitation, when do you get?
24 and a half. No invitation. First
Yeah.
invitation, 24 and a half.
Yes. Then, like ideally, of women, the test should be arranged within 6 weeks. They have to report for the test
Okay.
ideally. Okay.
Okay.
And 25 to 49 every 3 yearly,
Mm.
50 to 64 every 5 yearly.
Yes.
Above 65,
Mm.
like generally screening, if all the tests have been normal, no screening is required. However, if the previous reports have been abnormal or
Mm.
you are doing follow up for CIN, then only you continue the follow up. Otherwise, after 65 years, if all the previous reports are normal, no need of follow up.
Okay.
Okay. So this is how they go about. The first thing they do is HRHPV. That's it. Only HRHPV, right?
Okay.
They will, whenever the patient receives the invitation, it will be only HRHPV.
Okay.
Now, the HRHPV comes out to be negative. Then
Okay.
routine call.
Routine
So
recall.
depending on age, right? If
Okay.
the
After
patient
3 years.
goes for routine call, so only HRHPV will be done. No
Okay.
cytology.
Okay.
However, in case at any point HRHPV is positive,
Okay.
then they have to do reflex cytology.
Okay.
Okay. If cytology at any point comes out to be abnormal, what do they do?
They refer to colposcopy.
Colposcopy, exactly. In case HRHPV is positive but cytology is negative,
Negative. Okay.
okay, then they can
Rescreening.
rescreen in 12 months.
One.
Okay.
Okay.
Okay. Now, after 12 months also, if HRHPV comes out to be negative,
Okay.
then again the patient goes to routine call.
Okay.
Okay. However, if it comes out to be positive, then
Again.
reflex cytology.
Okay.
Okay.
When again the cytology is positive, colposcopy.
And negative, rescreen in 12 months. So up to 2 years you can do this.
Okay. Rescreening. Okay. Up to 2 years.
Yeah. So after 2 years, again you'll do HRHPV, right?
Okay.
Now,
Yeah.
if HRHPV is negative, the patient goes into routine call.
Okay.
HRHPV is positive. After
Okay.
24 months of follow-up, HRHPV is positive irrespective of cytology, whether it is negative, inadequate or abnormal,
Okay.
patient goes for colposcopy.
Okay.
Understood?
So for third HPV positive, okay, they have been referred to colposcopy.
Yeah. So can you tell me what is the primary screening that NHS does?
Primary screening, HPV.
Yeah. So HRHPV, if the screening is negative, then
If it is negative, a routine recall.
if it is
If
positive, then
if it is positive, we are doing cytology. If cytology is negative, rescreening in 12 months. If it is abnormal, colposcopy.
okay. After 12 months, if HRHPV comes out to be negative, then
Negative, again, routine recall. If it
positive.
is positive, cytology again. Cytology is negative means rescreen in 12 months. If it is abnormal, colposcopy again. After 2 year period of all these tests. If HPV is positive, colposcopy directly, irrespective of cytology.
Cytology, yeah. Okay. Now we have completed about the screening. Now,
Okay.
at any point when we have referred for the colposcopy, how do you manage? So colposcopy, the results you can get as inadequate or adequate. Okay.
Okay.
So
Mm.
what is inadequate? Where you are not able to see the transformation zone completely.
Okay. Mm.
Okay. So then what do you do? If it is inadequate, then
Mm.
you have to see what the cytology was. Okay.
Okay.
If
Mm.
cytology was low grade, okay,
Okay.
then you
Mm.
can just repeat colposcopy in 12 months. Okay.
Okay. Mm.
And after 12 months also, if it comes out to be inadequate, then you have to go for LEDs.
Okay. Mm.
Okay. And in case cytology is inadequate, however, cytology was high grade,
Mm.
borderline. Okay.
No. Mm.
Borderline into cervical, then you directly go for LEDs.
How do we know which is low grade and which is borderline?
So you classified a cytology as low grade squamous intraepithelial, high grade. High
Mm.
grade is one which has nuclear figures, all that,
Okay,
right?
so okay. This is they are obtaining from cytology report.
Cytology report, exactly.
Yeah, because only when cytology is positive, okay, those people are being referred.
Yeah.
But in the last scenario, irrespective of cytology, with HPV positive, they are referred for a colposcopy.
Yeah,
There,
it
do
was
they know?
about colposcopy. Now the patient has been referred for colposcopy. We are
Uh,
coming to management after that. So the patient, for any reason, if
mm,
cytology was abnormal, the
mm.
patient is referred, or HR-HPV is positive even after 24 months. Then again, you are doing irrespective of cytology, you are doing colposcopy, right?
No, ma'am. Like after 2 years, when HPV is alone positive, we are referring to colposcopy.
Yeah, that's what I'm telling
Okay.
you.
Yeah, even if cytology is normal there.
Yes.
How do they make out if they are under high risk or borderline or whatever?
The cytology picture. What do you do in cytology? You take a smear
Oh,
and you
okay.
analyze based on the cell
Okay,
picture. You
when they do
classify
that
as
thing.
low
Okay.
grade or high.
Okay, okay. Mm.
Okay. So
Yeah.
tell me, if the colposcopy is inadequate and cytology was low grade, what will you do?
Repeat colposcopy in 12 months.
And 12 months also inadequate then?
Then let's
Okay.
consider
And if it
let's
is inadequate and it was a high grade or
uh,
borderline endocervical, then?
directly procedure. Let's. Mm.
Okay. Now coming on to if colposcopy was adequate,
Okay.
then you see whether
Mm.
there whenever you're doing colposcopy, you
Mm.
take biopsy also from the abnormal areas, or if you
Okay.
do not see any abnormal areas, you do not take biopsy. So if no
Okay.
CIN on biopsy or no biopsy taken, okay,
Okay. Mm.
then how do you follow up further? So
Mm.
then again you go back to the cytology. You see cytology, if the cytology was low grade, the
Mm.
patient again you recall in 3 months, 3 years, sorry,
Yes.
36.
Yeah, 3 years. Mm.
Okay. In
Mm.
case it was high grade or borderline endocervical, then you
Mm.
have to get an MDT review within 2 months. Then you have
Mm.
to think why it is abnormal. Are we missing anything? So
And
you have to
what
discuss with the
what is
MD.
the colposcopic impression of CAN? Mm.
So colposcopy, you
Either
take a
no
biopsy,
CAN or not or either no CAN on biopsy or biopsy not taken or a colposcopic impression with the colposcopy they are able to say.
yeah, if
Mm.
if there are no SE2 white area, there is no
Okay. Mm.
then you put the this
Yeah.
glucose iodine, you do not
Okay.
see any abnormal areas. So
Okay.
that's how
Okay.
you can say there are no
Okay.
mosaic vessels, there are no abnormal vessels from which the biopsy have to be taken,
Okay.
right?
Okay, so this borderline is somewhat equal to high grade only. We should not
Yes,
underestimate that. Mm?
yes, yes.
Okay. Mm.
Okay.
Mm.
And in case the biopsy is abnormal, then you manage according to whether you get CIN 1, 2, or 3. You manage according to that.
Okay. Mm.
So tell me, if you have done the colposcopy, it is adequate and everything
Okay.
is normal. So no biopsy was taken, or you took the biopsy, it came out to be normal. Then how do you manage?
And we have to see how was the high risk HPV before. If that was
You have to
positive
see the
and
cytology.
mm,
You have to see the cytology. High risk HPV would be positive, then only you do cytology, right? You have to see the
yeah.
cytology.
Yeah, along with that, if cytology is low grade, we'll recall in 3 years.
Yeah.
Hmm. If
And
the cytology is high grade or borderline changes, we have to discuss with MDTT within 2 months.
yes.
Hmm.
Okay. So this is again the same thing which we have already discussed. So we
Hmm.
have completed this table.
Okay.
Now you come on to management of different types of CIN. One, two, three. So first we'll
Okay.
start with CIN one management.
Okay.
So
In
CIN,
questions, they are asking mild, moderate dyskaryosis. What do they mean there? Because in
that is
this,
a cytology picture. Dyskaryosis is a cytology
so
picture.
so mild means a low grade.
Yes,
Moderate comes under
borderline.
borderline. Okay.
Yeah. So now
Okay.
they have just classified as low grade squamous intraepithelial and high grade.
Okay.
There is no borderline according to the new guideline.
Okay.
Okay. Okay. So now if it is CIN1, okay, you can just conservatively manage these patients
Okay.
because the risk of chances to conversion to cancer is very less. It is less than 1%.
Okay.
You can just follow up these patients. So in case it comes out to be CIN1, you
Okay.
recall within 12 months.
Okay.
And in 12 months, if
Mm.
HRHPV, you see, what do you do in 12 months? You do HRHPV.
Okay.
If HRHPV is negative, then you
Mm.
directly recall in 3 months.
Okay.
Okay.
3 years.
In, yeah, sorry, three
Yeah.
years.
Mm.
And in case HRHPV is positive,
Okay.
then you see the cytology. If
Okay.
cytology is negative,
Mm.
but HRHPV positive, right? Then you
Mm.
again you can just wait and watch and recall in 12 months or 1 year.
Here recall in 3 years because HPV
Chance
is negative.
negative.
Oh, here
Yeah.
it is positive, but the cytology is negative. Okay, so again recalling in 12 months, like how we screened before. Okay. Mm.
Yes. Up to 2 years for CIN, you can wait. Okay, you can
Okay.
just monitor like that.
Okay.
Okay.
Mm.
In case cytology, at any point cytology comes out to be positive, you do.
Colposcopy only. Mm.
So cytology abnormal, you do colposcopy.
Okay.
Now at 2 years also,
Mm.
if HRHPV positive, then
Mm.
still now if HRHPV is positive and cytology is negative, you can
Okay.
just recall in 3
Okay.
years.
Mm.
Okay. If
So,
cytology comes out to be abnormal, you
mm.
refer to colposcopy.
So
And
first. Mm.
in case HRHPV is negative, you recall in 3 years.
Mm. Okay.
Okay. So
Yeah.
after 2 years, you can just if only HRHPV is positive and it was CIN and
Mm.
cytology is negative, then the patient goes back to the normal thing, recall in 3 years.
Okay, in the first follow-up, their recall is after 1 year, and the second time after 3 years.
No, it depends upon the second
That
time is also 12, 1 year only. First 1 year, then 1 year.
that is first. Okay.
Okay. So
After
if
HPV.
so now you tell me if
Yeah.
you get CIN, when will
Mm.
you call the patient on the
Uh,
biopsy?
after 12 months.
Okay, after 12 months, if HRHPV is negative, what do you do?
Negative, recalling after 3 years.
Yes, if it is positive, then
If it is positive, and when the cytology is negative, recall in 1 year. If the cytology is abnormal, referring to colposcopy.
great. And if after this second time also, if
Mm.
HRHPV comes out to be positive, then what do you do?
Positive. Again, in that case, when cytology is negative, recalling in 3 years. If it is
Yes.
abnormal, directly to colposcopy. And if the
And in
HPV is negative, recall in 3 years. So in the
yes,
third visit means this looks like second visit only. So if HPV is negative in 3 years, HPV is positive
in 2 years.
also 3 years.
Yeah, this is after 2 years of follow-up of SIN.
Mm.
1 year is 12 months and then again 12 months. Even
Okay.
if HRHP positive, cytology negative, you can recall in 3 months, 3 years, sorry, 36 months or 3 years.
Okay.
Okay.
Yeah.
Coming over to if it is more than equal to CIN2.
Mm.
Okay. Then how? Then you have to treat.
Mm.
Treat you. There are different types of treatment:
Mm.
ablative and incisional. For more than CIN2, you usually do excisional. You do
Okay.
LEDs or you do cone biopsy,
Mm.
depending on whatever you decide.
Okay.
After you've done the treatment, okay, we'll be coming to the treatment also. How do you follow up? So after treatment, you call them after 6 months.
Okay.
Okay, and do HRHPV. If
Okay.
HRHPV is negative, you can recall in 3 years. In case it is positive, then
Mm.
irrespective of cytology, because it was high grade, here the
Okay.
chances of cancer is much more. It is
Mm.
for CIN2, it is approximately 5%, and for CIN3, it is approximately 12.
Okay.
So that's why you cannot just leave it. So if
Mm.
HRHP is positive, so this is different from CIN1 because CIN1 has lower chance of development of the cancer.
Okay. Mm.
CIN2 we have higher chance. So after 6 months, if HRHPV is positive, then irrespective you do the cytology, but irrespective of cytology, you refer to colposcopy.
Okay. Mm.
Okay,
Okay.
understood. So
Yeah. Yeah.
tell me for CIN2 after you have treated for more
Mm.
than CIN2 or CIN3 after you have treated, how do
Mm.
you when do you call them for follow up and what do you do?
Okay. Recall in 6 months.
Okay.
When HPV is negative, again recall in 3 years. If high risk HPV is positive and cytology is negative or inadequate, whatever, we are referring to colposcopy.
Okay, great. Then this is
Separately, it's clear only, but all together have to remember some of everything.
yes. So
Mm.
this we have CIN1, we have discussed CIN2 more than equal to CIN2, we have discussed. Now coming over to CGIN or glandular intraepithelial neoplasia. So this is
Okay.
again a high risk thing only. For this also you have to treat
Mm.
and then recall in 6 months. If it is 6 months HRHPV negative, again because it here the risk is higher. So again you will recall in 1 year.
Okay, so it depends on the risk if it is after 1 year or 3 years.
Yes.
Okay, yeah, I will remember like that. Okay. Mm.
Yeah. So after 1 year, if HRHPV is negative, you recall in 3 years.
Okay.
Okay.
Mm.
And for CGIN in 6 months, if HRHPV comes out to be positive, then you do reflex cytology. If
Okay.
cytology negative, inadequate, you refer to colposcopy. If
Mm.
colposcopy is normal, then you recall in 12 months.
Okay.
If HRHPV is positive, cytology is abnormal, then directly colposcopy.
Okay.
Okay. So
Mm.
this is how you have to remember. Okay. So now this was about uh, when you are screening, you screen after 24 and a half years only. Suppose
Okay.
a young patient,
Mm.
20 to 24 years,
Mm.
present with abnormal vaginal bleeding, like a
Mm.
postcoital bleeding or persistent intermenstrual bleeding, then
Mm.
how do you manage?
Mm.
Okay. So because
Okay.
for them, we generally do not do HPV screening because it is not that accurate, right?
Okay. Mm.
And like since in this early stage HPV be carrying it,
Okay.
so patients you have to first
So
take detailed
we are not doing in younger age group because we get false negative,
false, you get false positive.
false positive.
Yeah. Okay. So
Mm.
at this age, so if you get a scenario with a younger patient with postcoital intermenstrual bleeding, so first of all you take a detailed history. In the
Okay.
history you ask if she was on oral contraceptive pill and if she has missed or not, or
Okay.
is there any unhealthy discharge.
Mm.
Then you do a speculum examination. On
Okay.
speculum examination, if you find abnormal suspicious of cervix, you directly refer to colposcopy under 2 week wait pathway because
Okay.
this here you are suspecting cancer. So
Okay.
you have to refer for colposcopy immediately within 2 weeks.
Okay.
And suppose you find a benign lesion such as cervical polyp, you
Mm.
you refer the patient for routine gynecological referral.
Mm.
And in case cervix looks normal, then you
Mm.
do a pregnancy test and test for any kind of cervical infection like chlamydia
Yeah.
trachomatis, Neisseria gonorrhea, or
Yes.
herpes.
Okay.
Okay,
Mm.
this kind of scenario you can get where you can get a young girl
Mm.
with post bleeding or intermenstrual bleeding. They'll ask you what to do. You will take history and do examination, speculum examination, and based on that, you'll manage. If abnormal cervix, colposcopy, 2 week wait.
Okay.
Benign polyp, you have to do. refer for
Okay.
routine kind of physical
So,
reference. So
okay.
if it's normal, then
So we are just referring. That's it. We are not doing examination.
yes.
Mm.
No, you are doing the
No,
speculum
no,
examination.
no, not,
That
no. I'm asking like we are not going for HPV. Okay.
yeah, not going for HPV.
Okay.
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 Now, when do you stop the screening?
Mm.
Okay. Suppose you have to do a early stoppage, like first, the if the patient has received prior radiotherapy to the pelvis. So in those cases, if the patient had received any pelvic radiotherapy, there is scarring. So it is very difficult to take the swabs.
Okay.
So do this like take the swabs for this HRHPV. So that's why you do not do it after radiotherapy to pelvis. Or if the cervix is absent, like if the patient has undergone total hysterectomy,
Okay. Mm.
or if
Okay.
unusually cervix, or if the patient has undergone a surgery from male to female transsexual, then obviously he will not have a cervix, or has undergone a radical trachelectomy where this for cervical cancer. So cervix is not there in all the conditions where cervix is not there, or prior radiotherapy. You do early cessation of screening before 65 years. Okay.
Being male to female.
Yeah.
That is trans women.
Yeah.
Mm.
Okay.
Okay.
What is the age of cessation of screening, cervical cancer screening?
For 64.
Yeah, it is 65. Yeah, after 65, usually they do not receive any.
Yeah.
Yeah.
If
So,
there was any abnormal report before, they may be on follow up. Mm.
yes. So, provided all these three criteria should be met. The most recent test was normal.
Okay.
Okay. The next test due would fall after the 65th birthday. That is who attends screening at or after 60 years.
Okay.
Okay.
Mm.
Or all of their last three screening tests were taken at appropriate intervals and all were normal. So all
Okay.
these three criteria should be met to say that you will cease further screening.
Mm. Okay.
And who have not responded to invitations will also be ceased. If the patient, if the person is not responding to screening invitation, then also after 65th birthday they'll not receive any invitation.
If
Okay.
they haven't responded to invitations, will also be seized means
They will not get any invitation per se.
no, like
Okay.
in at any age.
After 65th birthday. After their
After
65th birthday.
no, after 65th birthday, they are not going to invite first of all.
Yeah.
I'm asking like suppose a female of a 33-year-old not accepting the invitation.
Then they will receive up till 65 they will receive.
Oh, they'll be receiving only. Okay.
Yes. Only after 65th birthday they'll not receive. Okay, so if a woman has done a screening at 62 years, will she
Mm.
get a next invitation?
Sorry.
Last, if she has done her at 62 years, she had done a cervical screening which has come out to
Mm.
be normal.
Mm.
Then will she get another invitation?
No, she'll not.
Yes. Okay. So, whenever you are suspecting cancer, like
Mm.
if there is invasion, high-grade dyskaryosis, or glandular neoplasia, or borderline changes in the endocervical cells, so
Mm.
these patients they should be referred within 2-week pathway to the
Okay.
specialist clinic. And in case low-grade dyskaryosis,
Mm.
or borderline changes in the squamous cell or persistent high-risk HPV positive,
Mm.
then they have to be referred within 18 weeks pathway,
8
or if
weeks.
there are even inadequate samples. So whenever you are suspecting high risk of cancer within 2 weeks, low
Okay.
risk then
8
18 weeks. This you
weeks.
have to remember.
Okay.
And there's something which is called as faster diagnosis standard, that
Mm.
who are like if who are referred for investigation of suspected cancer,
Mm.
uh, find out within 28 days.
Okay.
If they, so their report should also be available within 28 days. The diagnosis should be made. Okay,
Mm.
you'll be referring to the specialist within 2 weeks, and the diagnosis should be made within 28 days. Okay,
Who are
that's
referred for
fast
the
diagnosis
investigation
time.
of suspected cancer, find out within 28 days. Or within 28 days, what do they do?
the diagnosis should be made.
We have to,
So if
okay.
you are suspecting, suppose you have done a colposcopy and it is, or you have done a cervical screening, HRHPV, it has come out to be positive and cytology is high grade, you're suspecting cancer, then within 2 weeks you will be referring to for the definitive,
Okay.
that is colposcopy and biopsy, right?
Yeah.
And report the final diagnosis, it should be made within 28
Within
days. That's what
28 days. Okay.
Yes. Okay.
Okay.
Then what about how to deal with inadequate samples? So when the HRHPV test result is unavailable or cytology has come out to be inadequate, the sample must be repeated in no less than 3 months. So then you can repeat at a 3 monthly interval.
Okay.
Okay. And the individuals who have inadequate cytology, even at 24 months repeated, like, and they are referred for
Again.
colposcopy.
Okay.
Or if they have 2 consecutive HPV unavailable or inadequate, then also you refer for colposcopy.
2 consecutive HPV unavailable means
Like you have done now, and then after 3 you have done the HRHPV or cytology, but it is inadequate.
okay.
Then also
HPV unavailable means negative or
the
cytology
report
is
is
inactive.
inconclusive or the patient has not done it, then also
Okay, if it
you
was
refer
not done.
for
Okay.
colposcopy. Yeah. Okay.
Okay. Okay.
Now, in case there are the patients present with symptoms of CA cervix,
Okay.
okay, for example, postcoital bleeding or persistent vaginal discharge, then they're not suitable candidates for screening. So they have to be directly referred for colposcopy within 2 weeks.
Okay.
Okay, so this is understood.
Yeah, yes.
Okay. Now, what is transformation zone? There are 3 types of transformation zone: type 1, type 2, and type 3.
Okay.
Type 1, where it is completely ectocervical, where it is fully visible.
Okay.
And or it has a small or large endocervical component, but it is totally visible. Okay.
It is ectocervical only.
No,
Small or large endocervical means any, but it will be visible.
yeah. What is a transformation zone?
Uh, between ecto and endocervix.
Yes. So we are talking about it. Either it is completely ectocervical, but it should be completely visible if even if small or large endocervical component is there. Okay.
Okay.
It has an endocervical component. However, it is fully visible. May have ectocervical component, which may be small or large.
Okay.
Okay. So primarily it is endocervical. Okay. But
Okay.
it is fully visible. Type 3, where it is not fully visible and it has a large endocervical component. May or may not have an ectocervical component.
Okay.
Okay. Now, in these transformation zone, like how do you decide whether you have to go for a biopsy or no biopsy?
Okay.
In case HPV is positive and but the cytology is low grade and colposcopy is negative, then you do not do biopsy.
Okay.
In case it is a high grade cytology and there is atypical transformation zone, then you go.
Okay.
Then we are talking now about the management. So there are 2 types of management: ablation. So ablative measures where you include where the entire transform are used, like in these cases you do not get sample for testing, right? You're just burning the area using bipolar electrode, monopolar electrode, like that. So in this you are not getting any sample. So you do it if the entire transformation zone is visualized. There is no evidence of glandular abnormality or glandular dysplasia or borderline changes. There is no suspicion of invasive disease. There is no major discrepancy between cytology and histology. No history of postcoital or intermenstrual bleeding. No gland crypt involvement or on punch biopsy, and no history of previous treatment.
Okay.
So in this, using cryocautery or freeze thaw freeze technique is used. You first initially there is this cold probe which is there, then you let it relax and then again freeze, like that.
Double freeze, thaw freeze.
Okay. So
Okay.
if
Okay.
the simple thing is, when you are not suspecting cancer, you go for ablation. Ideally, mostly
Okay.
you do
For
not go
low
for
grade
ablation.
CAN.
Yeah, because there are chances you do not get tissue, chances you miss. However, in periphery setting where a proper setup is not there, they
Mm.
are doing a like
Okay. So
CN
low
trees.
grade CAN, CAN 1.
See, it is CIN 1, 2, 3 is a biopsy, a histopathological diagnosis. So you
Mm.
cannot comment on it. But yeah, visually it doesn't look abnormal.
Okay.
That okay. Now
Okay.
excision. So how
Mm.
much to excise? Okay.
Mm.
So it depends upon type 1, whether type of the transformation zone. If it is type 1 transformation zone,
Okay.
then so
Okay.
type 1 you remove up to 1 centimeter.
Okay.
Type 2 you remove up to the depth of 10 to 15 mm.
Okay.
And
Mm.
type 3 you remove up to the depth of 15
15
to
to
20.
20. Okay.
Okay, you should aim at doing that.
Okay.
Okay.
Up to 10. Okay.
Understood, no?
Yes, ma'am.
Okay. It is 10, 10 to 15, 15 to 25. 1, 2,
Yeah.
3. Then high grade CIN if it is extending to the margins. So now what that means is you have taken the biopsy. Okay.
Okay.
Now
Okay.
biopsy if the margins have come out to be positive for CIN.
Mm.
This is what they mean, high grade CIN extending to the margins. So
Okay.
then what you, whether do you go for repeat excision or not? So routine repeat re-excision is not indicated if there is no evidence of glandular abnormality, no evidence of invasive disease, or and if the individual is less than 50 years. So in
Okay.
these cases usually you do not do re-excision. However, if
Mm.
the individual is over the age of 50 years and who have CIN3 at the
Mm.
deep lateral endocervical margin. So if the margins are positive for CIN3 and
Mm.
whom satisfactory screening samples and colposcopy cannot be guaranteed. So in
Okay.
these cases, you go for repeat excision. Okay.
Okay.
So if the age is more than 50 years and who have CIN3 at their margins, you go for repeat excision. Otherwise, routinely you do not do re-excision.
And in whom satisfactory screening samples and colposcopy cannot be guaranteed means doubtful cases.
Yes.
Okay.
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 Now, like suppose you have done the biopsy and it
Mm.
has come out to be 1A1. So whether
Okay.
you should go for repeat re-excision or not. So what like the endocervical and deep lateral excision margins are free of both CIN and invasive disease, then re-excision is not required.
Okay.
Okay.
Okay. Okay.
However, like for these patients, you have to refer them to gynae cancer center pathologist, and MDT team has to review their histology to decide whether they have to go for re-excision or not.
Even when the margins are free of CAM.
Then, if the margins are free,
Mm.
then usually re-excision is not required if it is only ectocervical.
Okay. Mm.
There is no endocervical.
Okay.
However, in
Mm.
cases you have to, it is always best to get an MTT review because if it is 1A1, it might be extending deeper. Okay.
Okay.
Then if it is a cervical glandular intraepithelial neoplasia,
Mm.
then in these cases, if it is these are usually seen in older age group. The chances of CIN is concomitant CIN is quite high, 50%, and
Okay.
these are usually multifocal and skip lesions are common.
Okay.
So you cannot ignore these patients, and you should have a very low threshold for colposcopy for CGIN.
These people are risk factors. Okay.
Yes. And CGIN also you have to do a 2 week referral pathway. If there is borderline changes in 2 week referral for colposcopy because of the high risk,
Mm.
and if there are borderline changes in the endocervical cell, you do colposcopy. If there is glandular neoplasia, again the doubt of glandular neoplasia, again refer for colposcopy. If it
Okay.
is endocervical, if it is non-cervical, you refer to the gynecologist for further investigations.
Okay.
Okay.
Mm.
And endometrial sampling is also indicated in individuals
Mm.
referred to colposcopy with glandular neoplasia or not otherwise because they can have concomitant uterine cancer also. Glandular could be coming from the uterus as well, right?
So, yeah. Mm.
So endometrial sampling is also indicated. So CGIN, all cases should be discussed with MTT and only excisional. Ablative is not an option for CGIN. Okay,
Okay.
this is again very important.
Okay.
Younger individuals, if it is younger individual, then and or individuals who wish to conserve their fertility. Okay,
Okay.
in those cases with colposcopically visible squamocolumnar junction, a cylindrically shaped cervical excisional biopsy, which should include whole transformation zone and at least 1 centimeter of the endocervix above the squamocolumnar junction should be removed. You can use loop or cold knife conization, or individuals can be managed conservatively if following excisional treatment the margins of the excisional specimen are negative and invasion is excluded.
Okay.
Okay, this is for younger patients.
Okay.
So younger patients, you remove the entire transformation zone and 1 centimeter above the squamocolumnar junction.
Okay.
Okay. In
Okay.
older patients who do not wish to conserve fertility, you remove the entire transformation zone and 2 to 2.5 centimeter of the endocervical canal.
Okay.
So you
There
are
only 1
regress.
centimeter. Okay. Here 2 to 2.5.
Okay.
Okay.
Now, if suppose you have removed, done the surgery for CGIN, you have removed. Okay. But it is completely excised. That is, the margins are positive.
Okay.
Okay. So then in these cases, you cannot like ideally it is because there are high chances of cancer. So ideally you should do repeat excision.
Okay.
Okay. However, if the patient says no, I don't want to go for a repeat excision, or it is not possible because of the technical reasons, then you have to do extensive monitoring. You have to monitor the patient at 6 months, 12 months, and then annually for next 9 years.
9
Okay.
years.
You will
Or
never go
until
through the
the age of
path.
65.
No, even beyond 65. If they have not completed follow-up, you will keep on following.
Oh, like 10 years after treatment.
Yes, annually up to total 10 years. So 6 months, 12 months, and then annually up to 9 years.
Subsequent of 9 years. Okay. So
Yeah.
altogether.
Even if it crosses 65, they will continue follow-up until they complete the follow-up.
Okay. Okay. Okay.
And
Whichever is the later.
yeah. And at any point, if high-risk HPV comes out to be positive, then direct colposcopy, regardless of what the cytology result is. And MTT should be involved. Okay?
Okay.
Because you have to be very vigilant for CGIN. Okay. Now, how do you follow up? So this first test of cure, if they previously I was telling if it was inadequately treated. Now, if it has been adequately treated, then how do you follow up? You first test of cure, you do it at 6 months after treatment that you were doing even for CIN, right?
Okay.
The same. But in these cases, you also have to do second test of cure, which will be 12 months later. That is 18 months after the treatment.
Okay. So.
Then 12 months or a total of 18 months. And if both are negative, then the patient goes to every 3 years.
First is at 6 months, then second is taken at 12 months later. Oh, that 12 months later or 18 months after treatment. So it is 6 and 18 months.
Yeah, total if you take. Okay. And what do you do in test of cure? You do HPV, and in case HPV comes out to be positive, you do reflex cytology. That is also if HPV positive, irrespective of what reflex cytology is, you have to refer for colposcopy. Okay.
Okay.
Okay. Now, this I've already told. For how do you? This is the same thing. Suppose this also same thing that if at any point HPV, any test of cure HPV positive, irrespective of cytology, you do colposcopy referral.
Okay, in incidental finding.
Yeah, and if colposcopy is normal also later, then also you have to do a complete 10-year follow-up.
Okay.
If it comes out to be positive, any test of cure comes out to be positive.
Okay.
So CGIN. So this we had not covered then.
Test of cure is that checking for high risk HPV only, no?
Yes.
Okay.
So CGIN, same thing. If you get CGIN, you treat. Okay, treatment will always be for CGIN excisional, right?
Excisional, yeah. No
Okay.
ablation.
Yeah. And after excision, when do you call the patient?
After 6 months.
After 6 months. And after 6 months, if it is normal, then when do you call?
Then after 18 months.
Yeah, total of 18 months or after, yeah, total of 18 months or 12 months after the first test of
From
cure.
the last one.
And if that is also negative, then
Then 3 years later.
okay. At any point, if the test of cure comes out to be positive, then what do you do?
We have to.
At any point, like at 6 months or 18 months, the test of cure, the HRHPV has come out to be positive. Then what do you do? Whenever HPV is
Colposcopy again.
positive, what do you do?
Colposcopy again.
Yeah, but also you have to do reflex cytology.
Yeah.
Irrespective of cytology, you have to do colposcopy. And
Okay.
in these cases, if any time HPV positive, then you do a complete follow-up for what duration?
When it is positive or negative, you are asking.
Positive. Negative, we have finished, no?
Yeah, when it is negative, 3 years.
No, I'm asking if any time test of cure has come out to be positive, then
Okay.
tell how much follow-up is required. Up to?
When it is positive,
You have done colposcopy, irrespective of colposcopy. If
when
colposcopy
it
has,
is negative, 10 years.
yeah.
Mm.
Negative never 10 years, no, negative it goes to 3 yearly follow up.
No, altogether, when only they stop finally. 10
65
years
years.
of
Then
treatment.
after 3 yearly it goes to the routine follow up, no?
Oh, until they turn 65.
Yeah, that follow up will be there, no, they will not leave it.
Okay, okay. Even after this routine recall, okay. Mm. Oh, that will be there apart from this.
Yes.
Yeah, okay.
Oh, you answer to my question what I'm asking. If
Mm.
HRHPV is positive, you
Mm.
listen to the question carefully, please.
Okay.
HRHPV positive.
Mm.
You have this was a patient who was being followed up for CGIN
Mm.
post treatment. You had done a test of cure at 6 months. It has come out to be positive. What will
Mm.
you do?
When it is positive, we do cytology.
Yeah, cytology. Oh, cytology negative. What do you do?
Colposcopy.
Yeah, irrespective of cytology, you do colposcopy.
Yeah. Mm.
Yeah. Then colposcopy has come out to be normal. Then
Mm.
when do you call?
Then 18 months later.
Why 18 months? Why 18 months?
No, no, 12 months. 18 months from treatment. From this follow up, she has to come 12 months later.
Yeah, recall in 12 months. Okay. Recall in 12 months. 12 months again normal. Okay.
Mm.
Then
Then 3 years.
no.
Mm.
For these patients, any test of cure positive, you do annual follow up till next 9 years.
Yeah,
Total
okay.
of 10 yearly follow up. They cannot go into three yearly pathway
Okay.
until they complete a total of 10-year follow up.
When is that 3 year? How I'm remembering is 6 months, 18 months, and annually.
This is when all HRHPV is negative. Test of cure is negative. This
Okay.
applies for that. If test of cure comes out to be positive, it is all the more risk, no?
Okay. Mm.
Not just leave them after to be monitored after 3 years, even if HRHPV is positive, right? You have to
Yeah.
keep them
Mm.
under more strict follow-up. So in those cases, you do every annual follow-up, 6 months, 12 months, and then annually up to 10 years. Total
Okay.
years or annually up to 9 years, next 9 years.
Okay. This is when they are normal, when it is going to be negative. If it is positive,
You see the flowchart and now you answer on your own because I've said the same 5, 6 times and
mm,
then again you're confusing.
here call in 6 months for HPV, 18 months, and then 3 years. What is this 3 years?
This is if HRHPV is negative.
Okay.
Then,
Then when annually?
if it is positive, what is so much confusing in
Uh,
this?
Yeah, got it, got it. If it is negative, 6, 18 and 3 years.
Yeah.
Okay. Like a routine recall. Okay.
Yeah, actually not routine recall. It will be 3 years. Like suppose even if she's falling, like if
Mm.
she's above 50 years, you have to do 5 yearly. But in these cases, you have to call after 3 years only. So that's why
Okay.
they have not mentioned as routine.
Okay. So what happens after this third year?
After third year, if it is negative, then routine. After that, if it is also negative, then routine.
Okay.
Okay.
Okay, ma'am.
However, now you just repeat if HRH, like you've done CGIN treatment, HRHPV positive,
Mm.
cytology negative, colposcopy you have done, which is also normal. Next, when do you call?
6 months.
At 6 months only, I'm telling now.
12 months later.
Yeah, and
Mm.
after 12 months, then
Annually.
up to
Up to 10 years.
total of
9
10
years.
months. Yes.
9 years.
Yes. Okay. Now, when do you do hysterectomy after CGIN? If the
Mm.
fertility is not required, or if the positive margins after adequate excisional procedure or
Mm.
treatment by excision is followed by high-grade cytological abnormality, or
Okay.
patient is unwilling to undergo conservative management, or
Okay.
adequate screening follow-up has not been possible, for example, because of cervical stenosis,
Okay.
or if the patient has other clinical indications to undergo hysterectomy,
Okay.
and it is done only after the invasive disease has been excluded.
Okay.
Follow up after stage 1A1, if you
Mm.
have done conservative management, if you have not removed, then
Mm.
again, for this also you have to do a complete follow up, that is 6 months, then 12 months, and then annually for the next 9 months.
Okay.
Okay. Okay. For
Mm.
1A2, 1B1, then
Mm.
you refer to gynecological oncologist. These patients have to go for simple or radical trachelectomy.
Okay.
Okay. If the patient has gone for total hysterectomy, then if there is no simple hysterectomy for any reason,
Okay.
so then there is no need to follow up them. Okay.
Okay.
And however, if suppose you've done hysterectomy and it has come out to be CIN,
Mm.
okay, so then these patients need further follow up. So you have to do it 6 monthly followed follow up with HPV. If it is negative, then you can discharge. Positive, you
Okay.
refer for colposcopy.
Okay.
And after that colposcopy is normal, again you discharge.
Okay.
You
When
have
it
to
is
take
completely excised.
okay, this is for completely excised
Okay.
CIN. If it is
Got it.
completely excised CIN, 6 monthly, but
Mm.
6 monthly you have to anyways. If there is CIN, you do a test of cure no at 6 months. So for this also you do a vaginal walt smear at 6 months. If it is
Okay.
negative, discharge.
Mm.
Positive, colposcopy. Colposcopy comes out to be normal, again discharge.
Okay.
Okay. Then follow up after hysterectomy. If suppose it was incompletely excised,
Okay.
so incompletely excised again you cannot leave it. So you
Mm.
have, if it is CIN1, the follow up is you can just do a
6,
wall
12,
sample at
24
6 months,
months.
months and 24 months. If it is CIN2 and 3, because there is
Mm.
high risk of cancer, so then
Mm.
you have wall sample at 6 months, 12 months, and then annually for the next 9 years, just like CGIN.
Okay.
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 And it continues up to 65 years or until 10 years after the surgery. So if this up to 10 years follow up is not complete and patient has reached 65 years, still you
Mm.
will continue until the complete follow up is complete.
Okay. Okay. With respect to their age. Okay.
Okay. Now suppose you have to take the sample but you find cervix to be stenosed.
Mm.
Then what you can do, you have three options. You can either do trial dilatation and take the sample, or you
Mm.
can, like if there was a past CGIN, then you can directly go for hysterectomy, or
Okay.
you can just withdraw the patient from the program. The patient is not willing for any of the option,
Okay.
and you have to re-evaluate for this at every screening episode.
Mm.
Okay.
Okay, ma'am. If all three options are denied, okay, they are